Welcome to the Chromatic Connection, a space where vibrant minds collide and the hue of human expertise blend into something extraordinary. I'm your host, Fatima Shirawi, and every week we dive into a kaleidoscope of ideas, stories, and wisdom shared by top industry experts. Diverse minds meet and ideas shine in full color. Welcome, Dr. Ihsan, to Chromatic Connection. We are very excited to have you today, and we have a lot of questions for you. So we first want to start with your journey. So what made you interested in this field? And tell us about Glucare and what makes it stand out comparing to the other centers treating type 1 diabetes.
Sure. Thank you for having me, Fatima. I started academically in engineering, so nothing to do with healthcare. And I pivoted to life sciences, so retaught myself a lot of the life science subjects that I didn't do before. Did a PhD eventually in gene therapy out of the UK at UCL. Started my career at what is called today Dubai Science Park, a part of Dubai Holding, essentially setting up the first life sciences building infrastructure, so labs can be a thing here. And then eventually moved to Mubadala Healthcare when it was more of a development company. Became the deputy CEO, and essentially during that 10-year journey set up many greenfield projects from scratch. So one of which was the Imperial College London Diabetes Centers. I was heavily involved in that, including their expansion into Al Ain, and then eventually inside a hospital called HealthPoint, which I was also the CEO of. So yeah, very broad infrastructure, greenfield development projects, essentially conceptualizing the project managing the construction of it, managing the business once it's ready, appointing teams, and then eventually sitting as board member and overseeing the original plan and if it's going according to it.
Amazing. So we really picked the right guest because you're truly an expert in the questions we'll be following today. So tell me the story about Glucare. How did you come about to create the center?
The basis started when I was essentially managing Imperial College London Diabetes Center. This is 3 outpatient centers, very traditional in its sense, but it's a one-stop shop for diabetes. The idea came when I was looking around and the mandate was given to me in that we need to create healthcare in Abu Dhabi at that time. We don't want patients to be traveling outside the country. We need also to take the chronic disease patients away from the inpatient setting into its own dedicated space. We knew that about a quarter of the population suffers from diabetes. And one of the mandates that they gave us is, it has to be self-sustaining. We can't have operating deficits forever. So the first thing I did essentially was go into a public healthcare system, the hospitals, and look at the workflow of a diabetic. And what I found out was quite shocking. There was multiple touch points, completely fragmented from each other. That a diabetic needs to see a diabetologist, but also needs to see a cardiologist, an ophthalmologist, and a podiatrist, and sometimes a nephrologist, and there's labs, and there's imaging. And this happens on a quarterly basis. So when I looked at that kind of chaotic workflow that a quarter of almost the population were suffering from in that inpatient setting, the idea came in, let's create a one-stop shop. Let's create super efficient workflows, in an outpatient center. And let's start with that thesis. So that was the thesis of the Imperial College London Diabetes Center. When I actually set it up, it was a huge success initially, in that it moved patients away from the inpatient setting into this kind of community setting. Very convenient for patients. Patients would go in and get everything done and leave and, come back every quarter. I started tweaking with certain things like real-time labs. Can we get labs done on site immediately? And this wasn't a thing, and eventually we managed to do it. The other aspect is, can I keep all the subspecialties that a diabetic patient would need, such as ophthalmology and cardiology, all in one setting? So essentially had the support system for an endocrinologist within the same setting. We did that too, and it was very, very successful. Now, over the course of 10 years, Around 2009, I decided that we have to start publishing outcomes. I wanted the center to be super transparent. One of the reasons why is we had market share. We had about 60% of the market share. And, the voices at the insurance side were getting louder, that this is, a center that's essentially taking quite a large portion of the diabetes spend. So, in order to defend ourselves and our positions, my decision was to essentially start reporting outcomes. If I'm going to be compared to other centers, I will be super transparent. So the first thing I did was to sponsor the standard sets for diabetes in an organization called the International Consortium for Health Outcome Measures. This is the global standard of every disease. It is a non-for-profit organization set up by Michael Porter, the Five Forces guy. We sponsored that diabetes subset. So if you're a diabetes center, you should be measuring according to the diabetes subset of the ICHOM standard sets. That's the first thing. So nobody measures differently from each other, and we can all compare ourselves. That includes mental health scores and socioeconomic metrics that usually most outpatient centers do not record at all. So that was the first thing. Now, I started reporting those outcomes from 2009. And I saw year on year, that we were doing a good job in terms of improving overall A1C. But considering the spend, we had a significant spend on that center from the government. Considering that amount of spend, outcomes in general were fairly poor. Average A1C at Imperial was about 7.5. Unfortunately, 75 to 80% of the diabetic population in Abu Dhabi, all diabetes, type 1, type 2, is classified above 7, poorly controlled. And, despite the center having no resource issues, so patients can get access, they can get the medications, they can get pumps and CGMs, we still had an average A1C of 7.5, 7.6. Now, it was brought down by about 0.9% over the course of 10 years. So when I looked at that, I started questioning, why is that the case? Are we never going to, drugs were getting better, access was getting better, devices were getting better, we had the educators, we had enough time to spend with the patient, and the question begs, what are we doing wrong here? Why are we not tackling this? Why isn't everyone below 7 in the well-controlled range? And it dawned to me that the problem with the system today is not the lack of medications or devices or education or access. The problem today is that the healthcare system is designed, let's say the incentives are not correct. We are designed to do what gets paid in terms of a service. We're not designed to chase an outcome. The problem today with also the operating model is that it's very episodic. You see a doctor every quarter, with a 10-minute snapshot of your labs primarily, with very little intake of what happens outside the center. So outside the clinic, which is where 99.9% of the decisions are made. They're not made inside the center. And that was kind of the pivot point to me to say, we have to move away from being episodic and only focus on medication as the solution to these patients, to being a practice that is continuous and have a behavioral change component as part of the therapy. This has to be standard. Now, when I proposed that to the management, they thought I was insane. They're like, how are you going to do this? How are you moving from episodic to continuous? Well, to me, it was easy. It's tech. CGMs are continuous. That's a great starting point. Why can't everything else in the patient's life, if we're managing that patient, but expecting the patient to self-manage all the other decisions that affect diabetes, which we're trying to help treat, it does not make sense to me. We should be part of that process too. So things need to be continuous. What affects people with diabetes today? It's obviously exercise and the nutrition and the medication compliance and sleep and stress. We're not collecting any of that today. So the idea to me came in that we have to move from episodic to continuous, and we have to have a behavioral change as standard not as advice that we give for 5 minutes in the clinic, but actually something that we're able to get personalized from a patient, and it's embedded into the clinical workflow, and it becomes the healthcare provider's responsibility to track that and do something with that data. That was the thesis of Glucare.
Wow, amazing. No, I absolutely agree with you. I mean, being a patient at Glucare, I saw the transformation with my case. And as you said, like before, I would take most probably a week when it came to like going to the hospital, waiting for my test results, even communicating with the doctor, of understanding, as you said, outside the clinic, what are the issues that are aggravating my diabetes, or what's causing me stress, or why is it so like I cannot control it. So the one thing that I liked about the center is the access. And as you said, it's very easy. We have so much technology now, and the easy access of being able to, for example, access my doctor at 12 o'clock because there is something strange going on with my blood sugar, or I have an emergency and I've made a mistake with my insulin. That panic that an individual has, before I literally had to wait till the morning till I could get an appointment. So here, even if it's not the doctor, but you have the rest of the team, the experts that immediately guide you through. So the patient themselves has a sense of ease because they already are dealing with so many other stress related to type 1. So I absolutely agree with you, and we currently have all the technology in order to have this model applied globally.
But if I ask you, Fatima, like why isn't anyone doing it? Like it's not rocket science.
Yes.
You know, maybe I'll give you some of the innovation we did in the clinic and then some of the innovation we did outside the clinic.
Okay.
But to have a continuous care model, if diabetes is 24/7, the care should be 24/7.
Correct.
It doesn't have to be emergency care, but it has to be accessible, and it has to collect the data points that affect that disease. Today, the only data point a provider, traditional care provider, does is, are you taking the medication or not? That's the only data point to know whether it's actually, their therapies are actually working or not. But they're not actually having a log of what you're eating or how you're sleeping or how you're stressed, all of which affect the outcome.
Exactly.
So it makes no sense to me. Now, when we start proposing it, why isn't anyone doing this? You know, this is not rocket science. You just develop tech, you just create new clinical protocols, and you train a workforce to start thinking like this. The reason why, and today, even though it's been 5 years since Glucare has been out, you know, and even though I've actually published the entire protocol of Glucare in the New England Journal of Medicine, fully transparent, 17 pages, I don't see a single provider doing it. Yeah. Why? This answer is simple. The incentives are not there. We only get paid for what the insurance companies will pay us. Like if the service is not a code, then they won't pay us. Nobody's paying us for behavioral change. No one's paying us for dietitians and educators and Oura Ring to track sleep and stress. You know, no one's paying us for tech to capture food log or incorporate food log technology. That stuff doesn't get paid. What gets paid for is labs and patient and physician visits and drugs and devices and scans. So that's what they'll pay for, and that's what you will see where the abuse is. Because most of providers will do a lot of that, but will do absolutely nothing on the behavioral side or the tech side or the continuous management side. So this is a fundamental problem we have today. And there's reasons why they don't pay for it. And we'll get into that. Yes. It's very important to, first of all, explain why it hasn't been done. Yes. If we are not incentivized on the outcome, why would I do it as a provider? You know, I don't get paid for managing Fatima as a patient better, you know, than somebody else. I get the same rate as I would with all my competitors because I'm doing the same labs and giving the same medications, etc. My cost structure under this hybrid care model that I've just described, where it's continuous in its behavior and you have a whole entire team following you all the time, is costly. It's higher. It's higher than somebody else. Right. But you see, we have to fundamentally change the way we practice medicine. We need to chase the outcome as providers. We shouldn't be chasing the revenue per patient. That this is because diabetics are very profitable patients to hospital. Everyone loves them.
Yes.
And they get bounced around different departments, especially in hospitals. They'll try to do as much as possible because they need that kind of care, but it's very, very profitable. But the minute they leave, they could not care less about what you're doing in your own life. And that's the sad thing about it. We've looked at it completely differently. We've looked at it that we have to change the care model from the beginning. We have to also prove to the world that this hybrid care model, where it's in clinic and out of clinic combined, where it's not just a physician, but a team approach, where it's not just diagnostics and therapy that moves, but it's essentially tech and behavioral change that's part of that care system. We've decided that, we have to move forward. We have to prove to the world. We have to publish outcomes. We can't just say it's better when it's not. It could cost a lot of money, but show no improvement. So, that was our journey. 5 years and 40 publications later of showing that this care model, whilst it makes total sense, is the right way. And the ADA, the American Diabetes Association, should change guidelines to promote these kind of care models.
Yeah. No, absolutely. And I remember I discussed with you, I was misdiagnosed for 4 years, and they just had to do one test to diagnose me as a LADA diabetic. And when I spoke to you, you mentioned to me that this test is not covered under insurance, so your standard doctor will not do this test.
Correct. It's for antibodies that you have to do. We do it for every patient, regardless if they've been diagnosed elsewhere, simply because we hear so many of these stories. You've been misdiagnosed as LADA. There are type 2s who are type 2s for 10 years who are not actually type 2s. And their A1Cs are 9 and 10, and they've been living like this, and their doctors have not actually thought about adding this test. Why? I don't blame the physician, obviously, all the time. But there's a partial fault to that. But if the test doesn't get paid and the patient doesn't want to pay, what are you going to do? You're stuck. We just do it regardless. It's such an important part of our process because we're chasing the outcome. So you might ask, well, who pays for it, Ihsan? We pay for it. I pay for it. It's fine. It's fine because I'm chasing the outcomes. And that patient, this is a chronic disease. If I wanted to be selfish and think about revenues, just revenues, I know that patient, if I treat them better than anybody else and I offer them the right care model and sort this disease out once and for all, I know that patient will be indebted to me and will stay with me. Exactly. It makes sense. They don't chase nice waiting rooms or polite doctors. They're chasing outcomes too. Correct. Patient. They care about their outcomes. They know that an A1C of 7.5 is disastrous long term versus an A1C of 6.5. They know that. They've been educated enough in that sense. So I want to just essentially put everyone below 7, and I know that they will continue to come and seek services at Glucare because I'm not going anywhere and disease is not going anywhere. Right. So we have to have that kind of thinking process behind. We have to have providers take some risk. Yes. Take risk, but they're not ready to do that.
Yeah, that I think is the main problem why they're not applying it. As you said, it's simple, but for them, what's the benefit?
Yeah.
You see. And this is a very good point. We can go into the whole topic of insurance. So if you could compare and explain what is the type of coverage for type 1 diabetes in UAE for locals and for expats?
Sure. Yeah. So for Emiratis, it's a lot easier because we don't have a churn in the insurance policy. Yes. You usually, from cradle to grave, you're usually with the same insurance company. So if you're from Dubai, you're Inaya. If you're from Abu Dhabi, it's Thiqa. And it's going to stay with you for life. Yeah. So the incentive for the government is obviously to take care of you as much as possible and to avoid the complications that you see with poorly controlled type 1 diabetes. And usually that's later on in life, primarily. With expats, which is 90% of the population, it's a bigger problem. They have 12-month insurance cycles. And, if a insurance policy today with an expat pays for the pump, for example, which it doesn't, but we'll go through that. If it pays for the pump, and that pump is, let's call it the Medtronic pump, you're talking 45,000 dirhams. Right. And the policyholder decides to change their insurance after 12 months because the premiums have gone up because they paid for the pump, and they can't do that. They're not obligated to stay. Right. Then, that's a problem. That's a problem for the insurance company that took that on. So there's no incentive to find solutions, whether it's preventative or coverage of medical devices or expensive therapies for insurance companies, because they have no guarantee that patient will stay with them. Now, if you were to ask me, what is the single biggest thing you would change in the system today, this broken system that we live, I would have abolished the 12-month insurance cycles. And most patients are covered under their employer insurance. We'll talk about the self-insurance, but most of them are covered under group insurance by their employer. And so the risk mitigation is much easier on that. So even if you are diabetic, you generally get good coverage under that. And even if it goes high and you have complications and you're overutilizing, then it's still fine under that. But if you were to tell me abolish it the 12-month and go into a 3 to 5 year contract with an insurance company. So as an employer, I can have all my staff or all my employees for 5 years under an insurance scheme. Then as an insurance company, I'm motivated to try to reduce overall spend. So prevention will become a thing. Offering pumps because they get better controlled, less complication will become a thing and can be covered for. Today, under 12 months, nobody's incentivized to pay for expensive devices. If diabetes is a problem, just look at pre-diabetes. Nobody wants to cover pre-diabetes because the return on investment is not in 12 months. The return on investment is over 10 years. It's the same as a well-controlled versus poorly controlled type 1. It's the same thing. If you're poorly controlled, you're going to cost the system more probably in 5 to 10 years when the complications start to come. If you're well controlled, then obviously that will be much less. So if I was an insurance company, I would want to keep this patient well controlled. So how do I get this patient well controlled? Well, obviously I want to give them access to good providers, number one. But the reality is I want to give that patient access to technology for improving their glycemic cycles. So, pumps and CGMs should be a thing, should be standard in this sense. But no one thinks like this, unfortunately.
And speaking of the pump, I know that you have a great program at Glucare when it comes to the coverage of pumps. So can you tell us the package that you have for that?
Sure. So, when we first started Glucare and we looked at the use of CGMs and pumps, look, I had an ambition. I told all these providers of medical devices, we have a problem. You're very expensive, you're inaccessible, and you don't get covered. All right. So we have to work towards a program or a strategy to eventually get you to a much lower cost or to figure out how we can give access to patients. So, I'll talk about the CGM strategy. When the G6 first launched, this is October 2020, the G6, Dexcom G6 was $500. Okay. And they had no market share in the UAE. It was all the Libre, 95, 97% market share. So I told Dexcom, this $500 would not work. I'm going to help you one day get the price to something cheaper than Libre. Okay, but let's start by giving out CGMs to patients for free. And they thought, this is not good. How are we going to ever make money? Typical medical device mentality. I said, well, that's my proposal. In return for giving it out to patients at Glucare, I'll publish how the G6 is great, and I'll publish, how people on patients on CGMs are better controlled than patients who are still doing BGMs. Basic stuff. So that's what we did. We did it for 2 years, and then we brought the price down stepwise. So we started giving the transmitters. You remember the transmitter before? We started giving that for free, because I forced their hand. I said, I'm not going to work with you unless you do this. And eventually, we met with their leadership, with the European, the American leadership. And today, the cost of a Dexcom is equivalent to Libre. In fact, it's slightly less now, which is incredible, the G7. But that is of years of pushing the agenda with them, publishing their data. Now they have their own reimbursement code they didn't have. We helped them get that. So all of that is part of the partnership to lower the total cost. I don't need to necessarily make any money on a CGM as a provider. I shouldn't be making any money. It's absolutely ridiculous. I should be making money on my outcomes, or at least on my services, but not on the products that are third party. I have nothing to do with. Now, when it comes to pump, Look, we struggled with these pump companies, and we struggled to convince them that you've got a ton of newly diagnosed type 1 patients who don't have access to this and they cannot afford it. So, I approached Medtronic at that time, 4 years ago, and they said, well, it is what it is. And they were market leader, and they're the only ones with the closed loop. So, started talking to other pump companies, introduced them to the country. Insulet was one. We launched with them here. We got their educators licensed at Glucare to offer free services to everyone. Right. As long as they come and see it, that service is there. But eventually, with time, I managed to convince Medtronic, and they had a great team there. They're very open, to start at least getting supplied at Glucare, because I wasn't even having their pumps. I would not accept that a patient had to pay 45,000 dirhams out of pocket. I just couldn't. Yeah. I didn't want it. So if they wanted it, I'd order it. But I don't want it sitting on stock and in front of patients to say, I want that pump. That's going to help me. Well, how much is it? 45,000. And they walk away disappointed with the whole process. I didn't even have them in the clinic. Eventually, I managed to convince them. And they were asking, how do we get involved? You guys are publishing a lot. This is great. We want to be part of that ecosystem. And I said, the only way you can work with me is if you give that pump out for free. Again, they thought it was insane, and they walked away. Yeah. But eventually, through the teams there, and I give them credit, they managed to convince their superiors that let's give out pumps for free. In return, I publish amazing data on patients who previously could not get access to this pump. Right. And now they have access to this pump, and look at the change we have in terms of their outcomes. Right. And for a Medtronic, that's the right strategy. So today we have a pump program with Medtronic, where the patient, if they cannot afford it, as long as they meet certain criteria, because obviously Medtronic still has to recover that cost one way or another, but there is no cost of the pump. There's still supplies. That's my next phase of how to get supplies sorted. Okay. But at least the 45,000 initial hit is no longer there. Okay. So we have a bunch of patients who joined us with this. We will start reporting outcomes. The patients are more than happy for us anonymized data to start publishing the improvements that they have using the closed loop technology that Medtronic supplies.
Right. And can you tell us more actually about the closed loop?
Yeah. Yes. Look, for us, the closed loop is going to be very standard in 2 years' time. Right. We just are a little bit behind getting the technology here. So the only closed loop today is the Medtronic system. The Omnipod 5 has a closed loop. We don't have Omnipod 5. I'm pushing them to try to bring it here. We have Omnipod Dash. Tandem is still not here. They have a closed loop. Like, there are so many solutions. And essentially, it just helps the patient calculate their insulin requirements based on the CGM. Again, the CGM interoperability is something important. Before, you had one pump working with one type of CGM. Right. That's usually the Medtronic approach. Yes. It's closed in that sense. Now you have this interoperability that happens. But going back to the question about expats versus Emiratis. So Emiratis, no problem getting coverage on CGMs and pumps as long as they go to a government center, which is another problem. Yes. Because sometimes they don't want to be managed in the government center. If you look at the outcomes, if they ever published, the last published outcomes at Imperial was 2019. Wow. A1C over 7.5. Okay, we don't have any outcomes from the government facilities, unfortunately. So, you're stuck. You're stuck there if you want your supplies. Yeah. That's one problem. But at least they can get it. That's one thing. I'll give it to you. At least if you need a pump and you poorly control type 1s, you should not have a problem as an Emirati to get a pump or a CGM. If you're Thiqa, go to the government in Abu Dhabi. Yeah. If you're Dubai, go to...
and they cover it.
From what I am aware, they cover it if you're type 1. Okay, yeah. Type 2s who are insulin dependent, tough. But they do cover it from what I'm aware. Selection, whether you can select pumps, I'm not 100% sure. I mean, there's only really one active pump provider here, which is Medtronic. I know Insulet is here too, but that's a consumable cost that is generally... I don't know if they accept that or what the approach is. Now, expat, totally different. It's not covered. The reason why, it could get covered. The reason why is there is a exclusion in medical devices and policies as standard. So if you are working for an employer and that employer provides you group medical insurance, Usually there are exclusions in medical devices.
Okay.
Sometimes they have limits. So there's inclusion, but the limit's like 1,000 or 2,000. It's not nowhere near getting you the supplies of CGMs or pump material. Now, if you were self-insured, and this is a big debate here in the UAE, there are a lot of freelancers. People have their own businesses. They're not part of group insurance. When you're self-insured, you have to declare your disease on the form. If you are group insured under an employer, you don't have to.
Right.
So if the bill comes for a consultation for your diabetes, you won't get dinged for that. But if you are self-insured and you do not declare that you have type 1 diabetes, then forget getting anything covered.
Right.
If you declare you have type 1 diabetes, then your premiums become so astronomically high that no one will actually join. And we've seen patients with 100 to 200,000 dirham premiums. This is type 1 adolescent kids. It's crazy. Or what is it going to be when they're a little bit older?
Exactly.
100 to 200,000. So we have to solve this problem in the UAE, especially now that we are a retirement destination. What are older, whether they're type 1 or type 2, if they declare it, what are they going to do? They can't be paying 200 to 300,000 in premiums just so they can access. Now, if you want access to devices and CGMs and consumables, and you put that on your self-insured form, it's going to go even higher. So it's almost better just to buy it separately. Now, we've tried to solve this problem with certain patients. So we've had a lot of patients who are struggling, self-insured patients who are struggling to get coverage. And we decided to go with a subscription program to say, look, this hasn't been tested globally. Subscription in healthcare is not a thing. Usually you expect your insurance to cover it. But we said, the concept of insurance doesn't make sense to me here. Insurance is when you have emergencies, when you have catastrophes, just like car insurance, just like flood insurance. You don't insure your car, expect it to be serviced by the insurance or change the tires by insurance. Right. It's the same in health. If you have patients with diabetes, they know what they're going to consume the healthcare services. That to me is a bigger story, but that to me should be covered outside of insurance. Okay, and they should go into certain types of scheme. Insurance is for the accident, for the cancer, for heart attack, for stroke. But again, we won't change that today.
Right.
So we decided, let's find a solution for these patients who are struggling to get coverage under a subscription program. So we decided to do that for type 1s, type 2s too, where they have unlimited care. Because we know what a patient with diabetes will utilize in terms of the services. So we said, okay, all labs, all remote continuous monitoring, all consults, and all diagnostics, as long as it's done within the 4 walls of our facility, should be covered.
Right.
Okay? And you can come as many times as possible, if you want. Now, we know that abuse doesn't happen. No one's going to show up every day, keep testing me. Right. And it's we priced it from a starting price of 695 dirhams. It goes up to like 995. So affordable, much more affordable than getting insurance. We tell them get the insurance for the emergency, but for your diabetes specifically, we have the solution. And we had a whole bunch of patients sign up to this because they were struggling. There were some patients who had their parents as type 1 or type 2. There was patients themselves. There's some parents of type 1s whose companies were not covering their kids who had type 1. So they all entered this program, and it's great value for money. We're not there to make money off of this program. We're here to try to break the insurance problem and just to essentially, to me, this is a research project. They get the care, but me, I want to present this data in 3 years' time to say, look, I've managed to, cover their entire diabetes needs under a subscription model, similar to a gym subscription, where the utilization is X, and this is what they do, and this is the outcomes of it, and can this be a future solution to what today has no solution, unfortunately?
Yes, I completely agree with you. In terms of also from a diabetic's perspective, I don't understand that why all the things can be covered. Like, for example, there are like certain cases that I was listening to in our support group. So some people, especially with like the CGMs, okay, I don't think it's like a one general fit for everyone. your body really is very, it really depends on your body, your lifestyle, how the CGM works with you. So in the last episode with Dr. Milena, I was telling her about where I tested out the G7 and the Libra to see the differentiation, how it worked, also in terms of like my lifestyle. For me, it was more convenient to change it 14 days because I'm on the move. For some people, it's easy, the 7. But what I saw in the group when we were discussing is that, like with insurance, it depends what device they cover. So, for example, that device doesn't suit your system, okay? But then you're stuck only using that because that's all that's covered. Yep. And this is where I agree with you. There's so much more that needs to be taken into consideration. And especially your research is what's proving to them. Because even with type 1 diabetes, nobody is exactly the same.
100%.
Each one literally has very different needs from the others. Whether it is the age or when they got it, or their lifestyle, or how much they even dedicate to maintaining their diabetes. And this is where I have the frustration too. Like, whenever I come into the clinic, like I'm always very happy because alhamdulillah, I'm able to afford whatever I need. I'm able to try the new technology, whatever it is. But then I think there's so many other people who deserve this and are not getting it. And it's just basically all about the profit of the insurance.
You're absolutely right. Yeah. You know, I'll give you some sad stories that we hear. So we occasionally invite some of our partners to present their products. So, whether it's pump companies or CGM companies or therapies, to come and present to parents. And we had one from one insulin pump company come and present to a whole bunch of moms and their type 1 kids. This was done during the day, and they didn't have to be Glucare patients. This is from the community, and we just brought it. And when the rep started presenting, this pump does this and it does this, and she, before she started, she asked the mothers, how many of your kids use a pump today? There was 1 out of like 15. I was looking at the background. I was shocked. Yeah. What, you guys don't use pumps when you have type 1 kids? How is that even possible? And I understand the affordability issue. And when she started presenting, the presentation and the benefits of the pump, you can see the distress in their, first of all, they are kind of embarrassed, but they're also distressed because they know that this exists, but they can't get access to it. And then the question started, how much does it cost? Can I get a discount? Can I ration, supplies? And it became a very sad conversation. And he said, okay, what is the problem here? And even if they were to access the pump and find a way to get the pump, like you said, everyone's different. They might not like that pump. That pump might not be the right one.
Right.
You're going to change from a Medtronic pump to something else, like a tandem pump. That's a huge cost. So if you make a decision, you're kind of stuck with it until the insurance decides to pay for it, or you actually can pay for it yourselves. And these are not solutions. This feels like we're stuck. And it doesn't make sense because this stuff is not new. Pumps are not new. CGMs are not new. And we're still stuck with the same basic question is, can I actually get it? You don't see this in other disease groups, in oncology, for example. General oncology, immunosuppressants, or whatever it is, therapies, they're accessible because that's the standard protocol for managing this. Right. You don't see this in cardiology where you start questioning, can I take this drug or not?
Right.
But when it comes to diabetes, because it's device heavy, the questions start. And for some reason, devices and medications are not classified as solutions, equal solutions. Yes. One is categorized as the superior solution, and the other one's a nice to have.
Right.
And that's how the insurance world has classified it. Now, you could also argue that these guys have priced it so high that it made it like this.
Right.
If they priced it low, everyone would pay for it. That's also true. Yeah. We can't also only just blame insurance companies who have cycles and they have to be profitable, and their medical loss ratios have to be calculated every year. Usually medical loss ratios are about 15%. So if you spend $1 on insurance, the insurance company does not want to spend more than 85 cents
Right.
on that. They want to keep 15 as the profit pool. That's how they calculate it. Anything above, it's overutilization to them. Anything below is great.
Right.
So this stuff utilizes because it's continuous. It's not a one-time thing. They can say, I'll take it one time, it'll improve, and that's it. This is a continuous thing. How do you factor that in group insurance, for example? You can't. You can't, because you can't actually tell the patient before, when they're declaring it, how many CGMs are using it, and which is your brand that you prefer, because there's price discrepancy. It's a functional issue in the industry.
Yes. And also, I feel like there should be also regulations with the insurance in terms of the accessibility to the public, because, like, for example, there came a time, I don't know why the Libra was out of stock, because like normal people or athletes were starting to use the CGMs for their personal monitoring. And here I always have this frustration. I'm like, it's our livelihood. What are you doing, And even, like, for example, like, okay, Manjaro is like sort of a supportive medication. And people are just using it. Yeah, they're just using it for vanity, I would say. And then there came a time there wasn't stock for it. Like I started, for me, like, Manjaro truly has helped in normalizing a lot of things, like not only my A1C, but also my mood, the spasms I would get, my energy. So it really is a transformational thing for type 1. And we started with the 2.5, the 5, and then I was stuck at 5 because there was no stock for 7.5. So I make people feel guilty whenever I see people who are non-diabetic and they're like, I'm on Manjaro. I'm like, you just took a medication from a diabetic pig.
That shortage was the summer of 2023.
Yes.
It we had fights at Glucare.
Yes.
We were one of the few, other than the government, to have full supplies.
Yes.
And when the shortage started coming, and we have a great relationship with the manufacturer of that drug, Eli Lilly. So they prioritized us as a key center. And we also do a lot of research with them, along with the government. Obviously, the government one's mostly on the diabetic side, not on the obesity side. Right. So when the shortage came, every pharmacist and every hospital in the city would say, if you want supply, because everyone was complaining, go to Glucare. They'll sell. They have all the supply. So patients would come in, not our patients, just patients, retail patients. Where is it? And they would see it in the pharmacy, and I want it. And we said no, because I had to calculate the dose for every patient for the next 3 to 4 months. Yes. So I would say, okay, this patient X has 2.5, and I expect it to go to 5, and I'll stay at 5, and these are 3 months for them. I wasn't selling it. It was stored for them.
Yes.
Okay. And that caused a lot of problems. I mean, pharmacies and clinical facilities don't think like that. Just, trying to secure medication stock for patients. There was a lot of weight loss patients that came and had that issue. But you see, even that whole Manjaro or GLP aspect of it, look, we use it as adjunct therapy to type 1s. Yes. You know this.
Yes.
We were one of the first to start using it off labels for type 1s. In fact, we published a paper last year, a 3-month study on patients with type 1 diabetes who were eligible on the weight loss side for a GLP. How does combination insulin GLP therapy work? Yes. And can it be controlled, or are we going to go into a lot of hypos here? We published that study and showed that we can reduce insulin usage by about 25% over 3 months. And you get all the other benefits, obviously, of reduced weight and more control over glycemia. Insulin is the tricky bit. Manjaro isn't, or GLPs aren't the tricky ones. So there is, adjunct, and we have it with SGLT2s for those with CVD risk too. So it's not just GLP. So I think this is going to be something that is going to be more common. Type 1s who use type 2 medications.
Right. And the thing is also, it's not covered, right, under insurance, the Manjaro?
If you are type 2?
Yeah.
So this is a good question, because this is another insurance issue.
Yeah.
This is primarily, again, a pricing issue. You have several medications in different classes that are priced differently. Okay, now if you are a type 2 patient, the way insurance wants you to behave as a provider is start them off with the cheapest medication possible, which is metformin, and get them on metformin with lifestyle changes.
Right.
And then if it doesn't work in 6 months or whatever, then get them on another medication, a DPP-4 or an SGLT2 if they have CVD risk, or a cheaper GLP, your Ozempics.
Yes.
Start them off with that. Show us that it's not working. And if it's still not working and this patient is poorly controlled, then give him Mounjaro. And it's only a function of price. Right. We know that, for example, these newer GLPs are better than the older ones and better than the older medications before them. We know that. And we want to start there because that'll give us the best result in the shortest possible time. Insurance companies do not like that. They want us to go in this kind of stepwise approach in medication escalation depending on price. I hate that because if there's a new medication that works better than the old one, now again, pricing is a government thing. They need to figure out if they want the best results, then the MOH should not allow for medication to continuously go up in pricing. Now, the new GLPs after Mounjaro, there's about 65 GLPs under production today. And they're going to be combo GLPs where you take a GLP, but you take something else to retain muscle. That's a new thing because, muscle loss is a big thing with the GLPs. Now, what are we going to do? We're just going to go from 1,734 dirhams per month. Mounjaro costs to 3,000 to 4,000 to 5,000. Like, it's going to go out of control.
Right.
Today, the average cost of a patient on Mounjaro, only the medication is about 20,000 a year. What's the average cost of an insurance policy? 10, 12, I don't know, 15, and this is without any other complication or any other testing. We have a mismatch. So you're going to get insurance companies attack providers for using expensive medication despite it being the best for them.
Right.
And now we're going to go into this gray area of who's in the right and who's in the wrong.
Right.
Can insurance companies really dictate providers what they should and shouldn't be using? I think yes, for providers that are not transparent, because there's economical benefit for them in over testing and over prescribing. But and this is why I keep going and advocating for outcome-based approach. And this solution will, by the way, we can solve everything that we talked about in this podcast in terms of pump coverage, CGM coverage, and GLP coverage, and any other medication that comes on. And we'll talk about the new medications that are out for type 1. All of this can be covered if they just go to a provider and say, I will cover you because I know you're reporting outcomes. If you're using these medications and these devices, but you're not improving patients, I'm going to take it back, or I'm going to stop future payments, or some other penalty to the provider. If this approach was there, then we're all incentivized to do it. I mean, as long as we can fix this 12-month insurance cycle, I would be happy to give all medications and all devices for free to patients. I would be happy to do that, knowing that if I improve the patient's outcomes because of my model, not just these devices and medications, and in 12 months' time, I come back with the outcome and say, look, they started it here, and now there's so much better improvement, and I share in the future costs that they were expected to pay because they were poorly controlled, I would go into that contract. Now, many providers will not take that risk. It's too risky. It's too long term. I'd be happy to do that, but everyone gets coverage. But we don't live in that world, unfortunately. We're living in a fee for service. Do the service, I'll pay you. If service is not paid for, I won't do it.
Right. The mental health aspect. The coaches are amazing in terms of, you have two types of coaches. So you have your insulin coach that really, honestly, personally has tremendously guided me in understanding how to take my insulin, what are the scenarios where I do my correction, even how to assess my body. Because sometimes, like with type 1, it's very unpredictable. You could do everything, you could take all your precautions, and your body just decides to have a hypo, or it just goes up for no reason. So that dedicated education in terms of the coaching is a key thing in part of the care. And as you said, this is not really covered under insurance. Another part is also in terms of the emotional maintenance, because of course, due to this chemical imbalance, you do have fluctuations in your moods. Sometimes you don't have even control over your emotions. And you feel very isolated sometimes. So the support group that you all created was wonderful because we kind of had a sense of belonging, and having the coach understand the things we were going through. Because normally, as a diabetic, usually you're like, I'm feeling this, I'm feeling that, and a person who doesn't have diabetes will tell you, oh, you're just overreacting, or, just go and relax or sleep. You're just stressing yourself out. But sharing your experiences with people who are experiencing, and then having the coach guide you how to process this. So a lot of the times it was about, am I feeling this because my blood sugar is unbalanced, or am I really reacting how I should as a normal human being to the situation? Because you do question yourself, I'll honestly tell you. Like with all this imbalance, you do sometimes question yourself or even your decisions sometimes. So this monthly meetings and having, actually, we'd set a goal every month, and then we would then recap. How did you deal with this, or why did you not deal with it? What is hindering your way? So this is not covered also under. Now, my question was, currently the government now has focused and has an entire program about mental health. So part of the program that's going on, do you see it covering this aspect of type 1 diabetic care?
It should be.
Yeah, it should be, but are they?
It's in the guidelines.
Yes.
There are many things in the guidelines that are not covered. A dietitian today is in the guidelines, is not covered. Let alone mental health and devices. The basics are still not covered.
Right.
Why are they not covered? I don't know. I do not know who decided that an educator or a dietitian or devices do not get covered. This is a cost-cutting thought process. I can't see it as anything else. If it's in the guideline, or they're not stopping you from taking insulin, obviously because you need it, but you also need the mental health support. Now, look, you said a very good thing. The key to improving diabetes, regardless of what your baseline is, people will always ask us, what is the thing that makes you guys different from everyone else? What is the one thing? Is it the facility? Is it the real-time labs? Is it the diagnostic that has an AI-powered software? Is it the continuous care model? Is it the engagement model? Is it the devices or the Aura rings or the fact that you do more? And I can tell you that there's no one thing that works, but I can tell you that the correlation of improved results comes down to one thing, and that thing is engagement. How you engage, regardless of where you start, is the key between a poorly controlled patient with diabetes type 1 or a well-controlled. And I'll give you this example. And we actually did a study, it was published in Frontiers of Endocrinology, a very well-known journal. We took 100 patients, from the system, not ARC patients. These are patients who were going to private centers and public centers in the UAE. And the criteria, this is on type 2s, but it'll give you a good example on type 1s too. Right. These patients had to be type 2. They had to actively be seen by a physician. So this is not someone who couldn't care less about his disease. He was actually seeing 2 to 3 times, up to 4 times a year. And they were on the latest GLPs. So it's not like we improved them because we gave them medication that they didn't have before. I wanted to keep it as neutral as possible in terms of, is the model of care that I'm providing, this hybrid continuous model of care, superior to traditional care, all else equal. So they're active seeing a physician, they're on the latest medication, and they're type 2. So when we took this 100 patients, and it was a slow enrollment because you had to find them, you had to try to get them, and you had to make sure they fit the criteria, the eligibility. Their average A1C, of this 100 was about 7.7 we saw, despite being on medication. And we said, okay, great. We know they're all poorly controlled because that's what the market shows. So we put these 100 into our program and we split them half and half. Half of them, they continued quarterly visits, but under a traditional care model. They would see their physician, do the test, they'd take their medication, they'd go home. Right. That's it. So they just did it with us because we could collect the data. The other half, we put them on the continuous model, where we gave them a support group. We gave them educators and dietitians and rings and tech and access to their physician on the app. And that was engagement.
Right.
So one is non-engaged, one is engaged. But the care is the same. After 1 year, we followed them for 1 year. After 1 year, when the 100th last patient came for the last visit, okay, we saw the results. The 50 that mimicked traditional care, their A1C did not improve. Obviously, nothing changed.
Yeah.
They took the same medication, and there was some improvement in some biomarkers. I think we spent more time in the clinic with them explaining, so they got we do more tests. So that there was some improvement there, but generally, overall, I could say there was no significant difference than when they started in another provider. The 50 that went through engagement all went from 7.7, 7.6 to below 7 with less medications. So, you can't point at the medication to say, this was medication effect. Yeah. So I said, okay, well, what is causing it? Then we looked at their starting points. We had starting points, A1Cs of 10, 9, 7. We even had some that were like 7.2, 7.1, even 7s. But the average was around 7.7. And we looked at, okay, how do they engage? Super engaged or lightly engaged? And we found that, and by the way, when you go from 7.7 to below 7 without changing medication, it's all behavior now. Yes. It's the only thing that we can play with now. So it's all behavior. It's like, okay, how did their behavior change? And what is the magic engagement number that gets them to the biggest improvement? And we saw that if you were engaged in 1 quarter, and remember, this was a study over a year, in 1 quarter, about 15 to 20 times, regardless of what your baseline A1C was, and regardless of who you're engaged with. So whether it's the educator, the coach, the doctor, doesn't matter. But the 15 to 20 engagement criteria had the biggest gains. There's a law of diminishing returns. After that, you don't see much.
Right.
Okay, and less than that, you don't see much improvements anyway. Yeah. Okay, so that 15 to 20 to us was a new parameter that helped us change the next iteration of Glucare's care model. Because I didn't know. I was kind of working in the blind. Like, just give them as much engagement and support as possible. But that's also not sustainable. Right. Because remember, all these services are for free to patients. So we had to find the right balance. So now I got the engagement model right. Okay, 15 to 20. Okay, then the next step is the mental health. Okay, there are patients today, as much as you give them support, they cannot go beyond the start of changing behavior. They're stuck. They're not at that stage where they contemplate changing mindset. Right. They're stuck. They need help. Yes. Okay, so we decided, let's also be smart about how our engagement is. Let's ask them at on-take, and there are these, we do the PHQ, the GAD, and the paid surveys anyway. Yeah. Okay, but let's ask them before they, we give them the app and the whole team and the village that goes behind them and engaging them. Are they ready to engage? Are they ready to change? Right. And what do they want to change? So rather than focus on everything, our old model was focus on everything. Okay, now our new model is get them to focus on what they want to focus, whether it's nutrition, sleep, stress, medication compliance, or food. Give them the right support partner for the first couple of months. Keep the engagement between 15 to 20 as per the studies. Okay, and then shift them over to the next engagement point. So if somebody says, I'm really worried about my sleep, I don't know what to do with it, great, because you know that they'll engage better in something that they're interested in, rather than forcing them with a nutrition coach. Yes. Let's get them to what they highlighted. Right. And are they ready to change? So there's a questionnaire we ask them, and if the scoring shows they're not ready to change, we stop and we try to get more therapists to get them to that point in time, maybe a coach that understands how to tip them over to that change, and that then it can either be continued with the life coach or continue to another coach. So we're trying to get smart also, because I want to do this at scale. Yes. If I wanted to do this at scale, I can't have an army of coaches and nutritionists and exercise educators, because it's going to cost a lot of money, and I'm never going to make any kind of sustainable business here. And I have to keep it sustainable. So that we have to be smart. We have to follow the evidence. But yeah, absolutely. The mental health thing has to be sorted one way or another. We hear these changes with the government, that policies are coming and mental health should be covered. In reality, I don't see it implemented. I see some coverage improvement. It's very limited. You have it's like your alternative medicine coverage and insurance. You have only 5,000 dirhams this year. to cover, and you decide between acupuncture and chiropractic. Who came with the 5,000? I don't know. It's a cost containment.
Exactly.
If that's my only therapy I need
Yes.
the whole year, should it really be determined on that?
Yes.
If mental health is the only thing I need today, why am I getting a limit of 5,000 and each session cannot be more than, I don't know what they put now, 400, 500. The problem is that mental health has no biomarker. You can stretch this out for a very long time, but I see it no different than diabetes. It's not like diabetes is going away next year.
Exactly.
So why are we classifying this? I think the minute mental health has a more tangible biomarker where we can measure improvement or not numerically,
yes,
we can start saying, okay, you know what, then let's create some coverage around that. But if it's open-ended,
yes,
I can get why insurance companies hesitate to pay for it. But look, we have a national strategy on mental health, but I don't see it being implemented today.
That's the thing, because even how you mention alternative medicine, there's a lot that also goes into the type 1 care when it comes to alternative medicine. And that I see at all not covered, even though the results are very beneficial and high from what I've experienced myself and even other people. But definitely, as you said, like diabetes is not going away. Even mental health is not going away. So I would look at it as, if you're going to look at it from a business perspective, you're going to make continuous money out of this field. You know what I mean?
Yeah.
So this is where I don't understand their approach.
By the way, type 1 diabetes and mental health are highly correlated to each other.
Yes.
What's the point of trying to manage a type 1 diabetes when he's got mental health issues? He can't even, the amount of decisions you need to make as a type 1 is multiple in a day. Tons, in a day. And if you had a overhang of a mental health disorder on top of it, you're going to prioritize the mental health side because you can't do anything with daily decisions. You're stuck. I mean, it could be different ranges of mental health, but today we ignore the mental health, spend money on the type 1, and then we question, why is it not improving, and why should we pay for CGMs, and why should we pay for... It's part of the therapy. You need them both. Okay. You can't get out of your... If you can't get out of your current mental health state to improve a disease, a chronic disease that requires so many decision points outside the clinic, that makes no sense to me. Like, you got to cover that first. And that's why we started asking the questions. But tell me one provider, I would even say globally at this point, that measures PHQ, that measures GAD, that measures PAID, and does something with it. Today, nobody's measuring it because it doesn't, even if you have a mental health disorder, so what?
Yes.
Like, what am I going to do with it? Your insurance is not going to cover it. I don't want to hire a therapist and offer it for free. I'm not incentivized. It makes no sense. That's why we started reporting mental health scores. We did quite a big paper on this to show the difference between mental health. And again, part of the solution is engagement. The more access to engaged or an engagement team there is, whether it's support group or clinicians or a life coach or a dietitian or your endocrinologist, we think the better the outcome. There are certain things that require specific therapies, and we are even thinking of adding these. Again, the cost is a problem, because do I offer it to patients who need it when the scores come out as required? Do I tell the patient, hey, you need to see a therapist or psychologist, but it's going to kind of pay, you're going to have to pay for this, or do I tell them, no, I will pay for it again, but then you start going into deeper and deeper red color in terms of your cost structure, and you don't know when it ends. That's the problem. Like, if I offer it for free, which I have thought many times, and this is a dilemma I face every day. Like, I want to offer psychology to these patients, but what if the patient needs 2 years of psychology?
Yeah.
And how do I do that in the absence of them paying for it or their insurance paying for it? I don't know. I haven't figured it out. With a life coach, you've got scale.
Right.
A life coach can manage 70, 100 patients because there's engagement points are limited. In this case, this is a one-to-one, maybe 3 times a week. I'm not saying it is, but it could be, where it's physical and that practitioner cannot see anybody else other than that person. You can't scale it the way that a life coach or a dietitian can use. And there's not many tools, digital biomarkers that I can create this on scale. And I looked at it. Can we do HRV for patients? If we manage someone's HRV and HRV improves, then that's usually a good sign for mental health. It's not directly correlated. They still need to speak to. I haven't figured this out.
Right. I mean, one thing to maybe like think of at this stage, I think you're doing a great job with the coaches, as you said. And I feel it's a very good sort of first level introduction in approaching the mental health. But as you said, there are certain cases that have other severe mental health issues, which is, I would say, would not maybe fall under the diabetic care. Yep. Which mean maybe partnering with actual psychology clinic would maybe be like you would be the first meeting point, the diagnosis, and then they would take it from there. That would be maybe like
we'll send them all to you.
An idea, yeah, exactly. But with me also, like what I practice, same thing. For me, I deal with the first stage, with the diagnosis.
Yeah.
So I have a lot of patients where, as you said, like sometimes they come once a week, where it's simple situation. It's life, normal stress situations. But when you have bigger issues, when say, for example, they're type 1 and they're bipolar, this is when you would take it to a bigger stage. There was actually a scenario which I completely thought about your center. A friend of a friend, and that person was born with thalassemia. Mm-hmm. And when he was a teenager, he got diagnosed with type 1.
Okay.
So imagine having 2 autoimmune diseases at one time. And I was so amazed with his acceptance, with his positivity and approach towards this. I mean, even told us a horrifying story where he went into a diabetic coma, and because of his veins, because of his thalassemia, they literally had to take the injection in his knees.
Oh.
You know? So and I asked him, I'm like, what keeps you so positive? Like, I actually even felt ashamed. I'm like, what am I complaining about? You know, my life seems normal as a type 1 when I'm looking at his scenario. And he said, he's like, I had a psychologist I used to go to, which supported me through the whole journey and normalized what I was living with. So this is where I'm like, it's absolutely right. And this is exactly what Glucare did for me and all the other patients, that they normalized our life, you know?
Yeah.
So definitely I would say maybe, you know.
Well, think about it. Look, yeah. I think I hope in 5 years' time, these conversations don't happen.
Yes.
And this becomes standard.
Right.
Like the fact that, okay, even for psychologists, but a life coach, I think that should be a standard protocol of care.
Yes.
If you have a chronic disease that requires so many decision points, then you should be offered at least a life coach.
Right.
Okay, just to talk about it. If you don't want it, fine, but it should be part of the service. Just like you'll get a CGM and you'll get insulin and you'll be taught how to use it. Just like you make food decisions, you should also be given a dietitian just to look over those decisions.
Right.
You know, this stuff, again, I'm baffled. Like, I don't get it. Maybe because I think a little bit outside the lens of traditional healthcare.
Yes.
It's, again, I'm following guidelines. I'm not creating this stuff out of nothing. I'm following guidelines, and the guidelines say you have to be offered with the following conditions and following support. And, you know, the tech side, I haven't seen it in the guidelines. So I think that'll change with time. Okay. Even to a point where, because we're monitoring patients continuously, do they need to come every quarter?
Right.
Maybe not. Maybe not. If we are able to track glucose continuously like we do today, but maybe ketones too, and then eventually lactate and other, other hormones, then maybe we can do it with 2 visits a year. That'll reduce the overall cost down.
That'd be great, yeah.
You know, I don't know, but like I want, and I've challenged the American Diabetes Association about this, and I said to them, guys, you know, this is an additional cost, but I'm supposed to reduce costs elsewhere because they're better improved and they're always engaged. So why don't you guys develop new guidelines about hybrid care models? Or I'm not saying totally virtual. I don't believe in complete virtual models, but they're behind. They're behind these small things like mental health and the fact that sleep affects, you know, your time in range, and the fact that we don't measure sleep, but we assume someone's sleep patterns are like that because we had a conversation with them doesn't make sense to me. I got to track it. It's a biomarker too.
Yeah.
So that's the kind of stuff I hope will change.
Right. Well, I think we can talk about insurance forever, but now I'd like to go into the technology in diabetic care. So let's take it in stages. Number one, what is the new technology or the adaptation of AI when it comes to the diagnostic part or the prevention part? And then the second part of the question would be is, what is the new technology available? And what is coming in the next, I would say, 5 years?
Sure. Let's maybe start with diagnostics. So when it comes to diabetes diagnostics, I mean, we've been using a AI-powered retinal scan for retinopathy screening for the last 4 years. This is probably one of the first AI software that came with an FDA clearance for a diabetic condition. Actually, it happened to be diabetic retinopathy. Now it's been expanded to age-related macular degeneration and other ophthalmic conditions that diabetes or that patients with diabetes generally suffer from. We already implemented that. The beauty is that you can get a report in 10 seconds. You don't need an ophthalmologist unless there's a red traffic light signal there. We started adding modalities around thyroid nodules and the fact that a lot of thyroid nodules were unnecessarily getting biopsies done. So we have the software, and patients generally do have or endocrine patients, those who suffer from both thyroid and diabetes, very common.
Right.
To find a solution around that and reduce the unnecessary fine needle aspirations or biopsies that happen. We have this software that does that. In terms of other AI modalities, I think when we talk closed loop, it's not really closed loop. It's kind of like semi-closed loop today. The decision-making process still lies with the patient. I think moving forward, and this has started to come out slowly, but I think what will happen is you'll get a closed loop where the calculations are being done, but it will start ingesting new digital pieces of information like your sleep and like your food log and like your exercise patterns. And these comes from other devices. So rather than just looking at CGM, determine the insulin dose, and you inputting certain things into the software, like what you ate or whatever,
right.
It just passively takes it from other devices because they all have an effect on that dose. And it does it automatically, and it does it with prompts. I think I don't see that more than 2 years away, honestly, because it's relatively simple to build.
Right.
I mean, if you feed it the right information, then it can come up and you can train it to be fairly accurate. I don't know if medical device companies can think like that, unfortunately. They're stuck in their hardware decisions. But some software company will come and probably overlay this on top of closed loop systems. So I think that's going to happen more. In terms of medications, I mean, for type 1s, we talked about adjunct therapy, so the use of type 2 and type 1 medication is going to be very common. We already started doing this.
Right.
With the eventual aim to make a type 1's insulin usage less, so hence less complications if something goes wrong. We're going to see indications around this, especially with the new type 2 medications on the GLP side that are going to come out. I think this is going to be something there. So we call it adjunct therapies, where we use type 2 off-label for type 1 patients.
Okay.
I think that'll happen 100%.
Right.
Cell-based therapies, the future. Like we've seen this company Vertex.
Yes.
I've seen their clinical results a couple of years ago, albeit in a small sample size. This is essentially to kickstart beta cell production in the pancreas. The type 1s cannot produce that.
Yes.
Unfortunately, that's why they can't produce any insulin.
Right.
That initial clinical trial has shown a 90% reduction in insulin usage for patients who do this. And the beauty about it is it's a single therapy or probably a protocol of a couple of therapies. The problem with that is that if it does come out, because it's a one-time or short duration, the price might go so high that it's excluded from every other payer discussion. And we go back to the same discussion with CGMs. Vertex is the company. I think they're the ones leading this. And we're looking at this with a lot of enthusiasm. There are immunotherapies out there. There was a drug that was approved a couple of years ago, Z-Shield. That's the brand name.
Yes.
It's for patients in stage 2, type 1 patients, stage 2, so pre-symptomatic,
Okay.
who can delay the onset of type 1 diabetes by a couple of years.
Okay.
So from stage 2 to stage 3, which it becomes clinical. Again, it helps rejuvenate the beta cell in the pancreas production, so you can produce insulin for a little bit longer. It's not a cure.
Yes.
So you just delay it probably by a couple of years.
Okay.
It's about to be launched in the UAE. I think the pricing, the problem is the pricing is high. I think the cost is around 60,000 dirhams.
Yeah.
But the beauty is it's a 14-day protocol, and that's it.
Okay.
You do it a couple of times, IV, and you're done.
All right.
You can delay it. We don't know how long, but the studies show maybe 2 to 3 years. If I was a parent who knew that the problem is the screening. You need to know that your child is becoming type 1, because there are signs, and unfortunately most parents, only the first time is in an ER.
Yes.
So preventative screenings, which is not a thing and should be a thing.
Yes.
If we were to do that more often, this drug would have a huge utility behind it. So I think those are out there. We continue to find new devices, new technologies. I continue to scour the market and see what there are, even if they don't have approval in the UAE. And this is the other problem.
Right.
You get something out, like the Omnipod 5. It's been out for a year and a half, and we have no visibility on when it's going to come here, which is ridiculous. But this is the process of medical device and pharma companies. They prioritize markets based on some strategy and also based on the reimbursement. So, we were very lucky with Mounjaro here. We were actually the first clinic outside the US to get Mounjaro, Glucare.
Yes.
And we were the second country outside the US to get it. And there's only a handful of countries that today have access to it.
Yes.
So that in itself is very good, and it shows that there's willingness, but because the reimbursement is high, and it was one of the causing factors of pharmaceutical companies to prioritize that country. If we were to pay 100 dirhams for Mounjaro, they probably wouldn't even think twice about coming here.
Right.
So there's this mismatch. I'm very interested with the new cell-based therapies, with the immunotherapies that are out there. My worry is the cost, because they're so effective, and they're usually a one-time thing, that they will price it so high that normal insurance, think of it, a pump is a 40 to 50,000 dirhams.
Yeah.
If that was let's say it's the same, you're not going to get coverage. And despite this being quite actually more valuable than a pump, because this might actually prevent the entire disease or cure it at one point with the likes of cell-based therapies.
Right.
I just don't know. And that's something that I think will require a government intervention to say, look, anybody who's diagnosed with type 1, if the therapy is out, they should cover it. It could start with the Emiratis. Definitely, I think that will be the case.
Yes.
And unfortunately, a lot of these companies that produce these new drugs, they're small. They're single product companies, that spent a ton of money on R&D, and they can't sustain themselves unless they price it as $100,000. And I understand that. This is not massive pharma companies here. And if it's a one-time therapy, there is no continuation of revenue. So I can see why it's priced like that. And you have to look at the economics. Otherwise, they wouldn't bother with the R&D.
Yes.
So this is going to be the dilemma, I think, of our times in the next 5 years. Okay. Both on the type 2 drugs, which are coming out, are going to be super effective. Some initial studies on the new Lilly product, retatrutide, is, you're talking 35% weight loss.
Oh, wow.
With relatively decent muscle retention. You're having all these type 1 immunotherapy drugs coming out or being in the process of approval. You've got also more smarter tech, better CGMs, longer life CGMs. I hope so.
Yes.
We move away from the 14 days just to become more sustainable.
Yeah.
We do see I think the Eversense is going to come in. The Eversense is the CGM where you implant it into your
yes,
body.
I've heard of it. Oh, so it's coming to
Look,
Dubai?
it's been around for a
Okay.
while. It's just never kicked off because I
Yeah.
think the patients might not be accepting of something
Yeah,
inside their body.
Yes.
But it initially was a 6-month CGM. You know, accuracy, I'm not sure about the MARD values, but I think it was around 10% if I'm not mistaken. So it's pretty good.
Yeah.
Would you put a CGM? And the other thing is the administration. If you ask your endocrinologist to
Yes.
do an insertion, they're not trained for that. So you have to
Right.
do it with a general surgeon or with a surgeon in a hospital. That's not really, I mean, once, maybe twice a year, maybe okay.
Yes.
But I don't know. Again, pricing. We'll see the pricing
Yes.
behind that. So yeah, a lot of cool stuff is coming out.
Okay, fantastic. We're looking forward to it. Anything that will make our life easier.
Yeah.
So great. Now we will answer some questions that have been sent in from our support group. Because I mentioned we have the expert today, so I'm like, ask all the questions you have. So we'll go with the first questions they had. So one of the question is why T-Slam isn't available in the UAE market.
T-Slim.
Yeah.
Look, they're available in Saudi.
Okay.
It is a decision whether to appoint a distributor or not. Very simple.
All right.
Whenever a medical device company wants to enter a market, they look at who the competitor landscape is.
Mm-hmm.
You know, is the competition so stiff with the established distributor network, with established insurance codes, and then they make a call.
Right.
Is this a big enough market or not? Now, the Saudi to them was much bigger market. Type 1s are covered by pumps, by the government, and it's mostly Saudis. We don't have the expat problem that we have in Saudi that we do here in the UAE.
Right.
Here, you know, you have, what are we now, 10 million?
Yes.
How many type 1 diabetics do we have? I mean, estimates, I would estimate, I don't know if this is right or wrong, I would say about 70 to 80,000, let's say. Okay, of those, what are the estimates of the national versus the expat population? Probably if we just go with a 10 to 90 ratio, you get 7,000 Emirati type 1 patients. I assume, I don't know, because no one actually has a record of this.
Yeah.
You know, is that a big enough market to try to break Medtronic stance here? I don't know. I've asked them many times to come, by the way, Tandem, and I've told them I'm happy to, you know, go into any program, but patients love that pump, by the way.
Yeah.
They do love it.
Yeah.
It's a beautiful pump. I think it's priced well. So yeah, we keep trying.
Okay.
We keep trying.
All right, great. All right, our next question. This was actually like 5 people asked this question. It was a very popular one.
When are we opening more centers?
Yes, we do want more of you everywhere. Another question was about the wireless pump.
Okay.
So they wanted to know more about this wireless pump.
Yeah, I mean, by wireless pump, I assume things like a pod therapy, like Insulet's Omnipod.
I think the Omnipods.
Omnipod. I mean, we use Omnipod 5. We introduced it in the market.
Yes.
Patients like it because it's disposable. You do have to use a PDM. I think the Omnipod Dash, you have to use a PDM. The Omnipod 5, you no longer have to use it.
Yes, that's
so it's available. There are others in the market, but I don't think they're available in the UAE. I think, if I'm not mistaken, Omnipod 5 is available. Obviously, cost, I don't know why. I think it's around 3,000 a month for the pods. It's a 3-day use per pod.
Yes.
Again, you can change locations in your arm or in your stomach.
Yeah.
Patients like that, you can put it on your back. So tube free.
All right.
Children generally like that when they're at a certain age, because the tubes are a problem for certain teenagers especially. But yeah, I think it's a great product.
Okay, great. All right, next question. Will we be getting any inhalable insulin?
Afrezza.
Yes.
I did look at this.
Yeah.
Afrezza is not available in the UAE. I thought of importing it with a license.
All right.
I'll tell you the problem with that. First of all, it's not reimbursed. Okay. Second of all, very few doctors have been trained to use it. because it's just not available everywhere.
Right.
I did discuss it with my clinician group, and I said, do you think there's a market for it? I'm happy to bring it through a special exemption or anything like that. And the consensus was, we don't think there'll be enough demand for this. So we didn't bring it.
Okay.
Yeah.
Right.
I think also there's certain risks that physicians are not comfortable with. Most people are not taught how to use a Freza.
Right.
There's no distributor. There's no supply that explain it. So you gotta have to self-learn it.
Right.
There was some debate about whether it's efficient. It was actually helpful in managing diabetic. I think you still have to use it with normal insulin as part of your treatment plan.
Right.
But yeah, I did think about it, and if there is certainly a demand for it, I can relook at introducing it, because I'm always trying to find solution. And by the way, this is an old product.
Right.
This is not. There's no new version of it.
Yes.
I think eventually it was sold to a smaller pharmaceutical company.
Right.
I think that whoever had it originally just didn't see a path for it.
Okay.
It's not super cheap too. I can't recall the price, but it wasn't cheap like your normal insulin.
Right. Right. So there are many different aspects actually that you look at it when it comes to this.
Yeah.
All right, great. Okay, so there was one patient that was saying that they are a type 1, and the doctor is currently, I guess, diagnosing them as LADA because they're saying that they're turning into a 1.5, which is a LADA. But their insurance coverage does not cover approved medication which is used for like type 2 for type 1.
Yes.
Yes. So
look, again, it's like if you're type 1 or LADA and you want to get type 2 medication approved, they will not approve it. So if you're using like I said, adjunct therapy, Mounjaro for LADAs, it's considered type 1.
Yes.
It's out of pocket.
Yes.
It's for weight loss. It's not for the diabetes anymore. It's silly. It's silly because both together can be a combination therapy approach. Right. But that's unfortunately how it is. Even in type 2s, they can't get certain of their medication approved. Believe it or not, it's easier to get insulin approved for a type 2, which is insane because nobody should be on it, honestly, with these GLPs, than a Mounjaro.
That is so strange.
Yeah.
Oh my God.
Because it's cheaper. That's why.
Yeah, it all comes down to the money. All right. Okay, one question is the impact of Jardiance on type 1 diabetics?
I don't know this. This is something you have to ask Dr. Milena.
Okay, all right. So we talked about stem cell therapy. One of the questions was, when should we expect stem cell therapy to be approved commercially? And if it ever does, would it be covered by insurance or not? I think we covered this.
Yeah, look, it'll take... It's in phase 1 now. It's going to phase 2. There's been some hiccups, and they stopped the trial. They restarted it. I can't see it less than 6 or 7 years away, unfortunately.
Yeah.
There are things like insulin resensitization therapy. I don't know if you've heard of this.
No, I haven't heard.
Where they give you insulin in using an IV pump. So you come in, I can't remember, a couple of times a week, and you are given microdosing of insulin to resensitize your pancreas. Okay. It's more of a type 2 protocol. There's no real ground evidence. I looked at bringing it at one point. The doctors were uncomfortable, and they said, look, it's rationally thinking, it makes sense when you microdose it slowly enough that you can start reproducing it again. Right. But it's not in the ADA guidelines, and that's a risk.
Okay. Yeah, you see, that's the issue of like a lot of people who are on the pump. So what happens is, because the pump is continuously, producing the insulin, and sometimes your activity or not eating for a long time gives you the lows, but you're still continuing having the insulin. Yeah. So a lot of people suffered from having the hypos and then decided to be off the pump and go back to using the insulin. This is like a very common problem that like people in the group discuss. Yeah. And also it kind of takes away from you sort of assessing the amount of insulin you need. you know?
Yeah.
So when you take the pens, you're more in control.
Are you using a closed loop?
No, I've never used the pump. I've always used the
MDI?
pen. Yeah.
Have you used the new smart pens? Have you seen those?
Yes, I saw the smart pen, but I don't know, for like the way my lifestyle it didn't suit me, but
Yeah.
I did like the idea of the smart pen.
Yeah. Look, I think with proper closed loop, this will go away, this problem.
Yes.
Because you won't get the dose.
Right.
It won't be calculated. The smart pen today that we have a smart pen, we sell it. It's a Medtronic pen. It used to be called InPen. It was done by a company called Companion. Medtronic bought them off, and now it's become part of the Medtronic.
Right.
And originally it was supposed to be a pen that was open to using any type of CGM. Unfortunately, now it's just the Guardian CGM by Medtronic.
Right.
So they made it their own closed system.
Okay.
Now that pen they call it a smart pen, but it's not really smart.
Right.
It doesn't, it'll calculate,
Yes.
but you're still going to have to inject it. I think that'll get better with time. I think there'll be more smart pens. Are people willing to pay? It's not an expensive product, by the way. It's a one-time cost, and you just put your insulin in there.
Yes.
It could be helpful for people who struggle with the calculations, but you got to use the Guardian.
Yes.
And that's a 7-day sensor.
Right.
Some people don't like that.
Yeah.
But I think as long as we start getting the pumps and the CGMs with more interoperability coming up in the next year or two, the AI software is not going to, in my opinion, be created by those companies. It's going to be third-party companies that bring them together and get the FDA approval for the entire classifications of pumps and CGMs,
Yes.
which are going to be better than the ones that the manufacturers themselves do, because they are behind in this sense. I mean, you have loopers today who've created their own closed loop. These are hackers, type 1s,
Okay.
who do not who use the hardware,
Yeah.
but they completely dismantled the software. They created their own software, and they've done entire closed loop systems, so they can pair an Omnipod with a Medtronic CGM, or a tandem pump with a CGM that's today not compatible. Do
Yes.
not use the software of either companies, and has worked very well. I think that is, and by the way, you can kind of do it yourself. I'm not advocating for this, but we have patients.
Yeah.
We call them loopers.
Yes. Yes.
They created their own, and they're their own community. They code
You're right.
this stuff, and it comes up with updates all the time.
Fantastic.
And some of them swear that this is much better than any other existing FDA-approved software coming from the manufacturers. Again, this is something very delicate,
Yes.
because we got to go with the approval process, but they say that it works for them.
I think with me, with the pen, was because like I had to put another sensor with the sensor I already have. I think that was my reason of why I had enough sensors on. But definitely it's something to consider. As I said, honestly, it really depends on like your lifestyle and how you manage it. Like if it's suitable or not. Like for people like on the go, it's super easy. Like you really, with each one, you kind of pick it for your lifestyle.
Yeah.
Okay, so great. So is there anything else in our final points that you want to share, or make people sort of aware of certain things they should consider when it comes to insurance, or consider what sort of technology is best for them going forward?
Yeah. So obviously we can help a lot. Like, again, we try not to align ourselves with any one partner. We try to give the entire choices. We're not aligned. Let's say we have partnerships with all of them, but there's no obligation for us to push any product in the market. And I've been very, very clear with my team. There's no preference. So I would suggest anybody who has a concern, come speak to our educator, get to know all the pumps and all the CGMs that are available in the country. We have them all, and we brought a lot of them. And if we don't have them, but you've imported it from another country, we will try to understand it and go into the softwares and be able to track you from that. So, give our center a call, talk to the educators. If insurance is a problem, also speak to our team. We will guide you in which insurances are cover you better for your condition, although it is a pain for all of them. That's there. If you do not find a solution, obviously we have our subscription program. It's very affordable. At least get you covered for your main diabetes needs. So yeah, we're always going to fight for the patient. We will not rest. I will fight the pharmacy or pharmaceutical companies. I'll fight the medical device companies. I'll certainly fight the insurance companies and the regulator here to try to, help patients get easier and accessible care. Easier is a big word because I don't want this to be a burden to continue to have. So what I've tried to do with the concept of Glucare is at least the care should be simple. Okay, how do you get paid for it? That's my problem. I will fight that battle on behalf of the patient as much as I can. Yeah. That's why I've gone into these programs and offer a lot of services for free. The regulations about getting mental health coverage, I continue to discuss as much as I can with the regulator. Obviously, I'm still small. I'm still just one center, hopefully more centers soon. Actually, 3 months we'll have a new center. So it's something I believe that every provider should do. We can't just be a provider and just bill insurance and make money and that's it. We have to forward the agenda of this, what I consider a national problem. It's a kind of a national catastrophe, actually. Every family has it in this country. And it's insane. It's the only thing that actually commonly unites us is the fact that we know somebody in our families has this disease.
Yes, absolutely.
And it's whether it's type 1 or type 2. So I think it's on us to find a national solution. I'm happy to be a small part of that contribution. And in fact, I believe in the model of care so much that we're not going to go export that model of care outside. I want this to be an Emirati solution that we export for the first time rather than bringing names into our country. And we've seen the names that come in diabetes, whether it was my previous organization or the ones that the government affiliated to. I have to ask, have they actually helped improve the care outcome? Because they all kind of practice the same thing here. No one's differentiating themselves. No one's being accountable to that. So I always look at, if we've got a national problem and it's primarily in the GCC, why can't we have a national solution? We get national champions to find the solution. We obviously need national support for getting it. Otherwise, I'm banging my head against the wall and I won't get anywhere. But I am getting somewhere. I think so. And let's export it. If we are doing something because we have the population better than everyone else, let's show the others what we do. And we'll be announcing this soon. So keep it as a plug. But we'll be announcing our first international expansion soon, in a couple of months. I do believe that our model should be replicable. And I believe every diabetes patient will be better off in our kind of hybrid care model. It doesn't have to be done by us, but as long as the model is replicated, they'll have better outcomes.
Fantastic. Thank you so much for sharing your knowledge, giving us your time, and I truly, truly wish you all the best. And I am a true believer that you're going to go international. Sure. And as an Emirati, I'm very proud that you have created something so remarkable. And as you said, why not we as Emiratis create something international that can be applied and people come to us for the knowledge. So I wish you all the best and thank you so much, Dr.
Thank you, Fatima. Good to speak to you.
Great. And that's a wrap on today's Chromatic Connection. A huge thank you to our guests for sharing their brilliant palette of insights with us. If this conversation sparks something in you, hit subscribe, leave a comment, or share it with someone who'd love to add more color to their perspective. Until next time, remember, life's too vivid to stay monochromatic.